Welcome to the Black Belt Nurse Podcast, where we discuss all things related to violence in healthcare. I'm Bill Schuler, your host, and this is the place where we learn together, mull things over, and generally figure things out. Whether you're a seasoned expert, a student, or just passionate about safety in healthcare, this is the podcast for you. Before we dive in, a quick disclaimer. We do discuss all aspects of violence in healthcare, some of which may be inappropriate for younger listeners and viewers. Please use discretion. The Black Belt Nurse Podcast is for informational and educational purposes only. While we discuss experiences, strategies, and science, this podcast does not provide medical, legal, or professional advice. Always consult your healthcare institution's policies and guidelines or seek professional advice when necessary. And of course, all opinions expressed here are my own and do not represent any employer or organization. Now, let's get started. Welcome to this episode of the Black Belt Nurse Podcast. Go ahead and like and subscribe and hit that notification button so you're notified when new episodes drop. Today, we are again getting into something that I think about a lot: behavioral flags, violence risk flags, safety alerts, the little pop-ups in your EHR that says, "Heads up, this patient has a history." 6 research studies have come out over the past couple years that are getting a lot of attention in healthcare circles, raising questions about whether behavioral flags are being used equitably. I want to talk about all of them because nurses deserve to know what the research actually says, not the headline, not the social media summary, the actual findings, and the actual limits of those findings. Because here's where I'm coming from before we even start. I've helped create violence flagging programs, and I've directly benefited from them. I believe behavioral flags save lives. I believe your right to know when you are walking into a potentially dangerous patient encounter is not negotiable. And I believe we can take equity seriously and take staff safety seriously at the same time. Those are not mutually exclusive, no matter how some of these studies seem to frame it. So let's dig in. Let's read the fine print. And let's figure out what the science actually tells us and what it doesn't. Before we get into the studies, let's anchor ourselves in why behavioral flags exist at all. Because sometimes in these equity conversations, that context gets dropped entirely. Emergency department nurses are physically assaulted at work at rates that would be completely unacceptable in any other profession. We're talking 70% of ED nurses reporting physical assault. 70%. Hitting, punching, biting, spitting, sexual assault. These are not rare events for many of us. They are part of the job as it currently exists. And when you've been assaulted, when you've watched a colleague get hurt, the question isn't abstract anymore. You want to know. You want that pop-up. You want a heads up before you walk into that room. Behavioral flags were created to fill exactly that gap. They're a communication tool, a way for one clinician to pass critical safety information forward in time to the next clinician who sees that patient. And in the absence of anything better, they have become the primary tool many institutions have for that purpose. Do they work perfectly? No. Can they be misused? Yes. Does the research we're going to discuss today raise legitimate concerns? Absolutely. But hold on to that baseline as we go. Flags exist because nurses are getting hurt, and we deserve tools to protect ourselves. Let's start with the 2 largest quantitative studies in our review, and I want to spend real time on both because they carry a lot of weight in how this conversation is being shaped. The first is Agarwal and colleagues, published in JAMA Network Open in 2023. They analyzed nearly 200,000 unique patients across 3 emergency departments in Philadelphia over a 3-year period, more than 426,000 total visits. The research question was straightforward. Are Black and white patients flagged at different rates in the EHR? And do those differences persist after you account for clinical and demographic variables? They found that approximately 0.3% of patients, About 3 in every 1,000 had at least one behavioral flag. But that rate was not evenly distributed. Black patients were flagged at a rate of about 4 per 1,000 compared to 2.4 per 1,000 for white patients. That gap remains statistically significant even after adjusting for age, sex, insurance status, and psychiatric diagnoses. The study also looked at what happened clinically to flagged patients and found that they waited longer, had fewer diagnostic tests ordered, and had shorter lengths of stay. For frequently returning patients, the disparity was even starker. Those who visited the ED more than 18 times over 3 years were flagged at a rate of 178 per 1,000, nearly 50 times the overall rate. The study concluded that Black patients face higher odds of being flagged and may receive different care as a result. The second study, Haimovich and colleagues, published in Annals of Emergency Medicine in 2024, went significantly larger in scale. They examined nearly 3 million emergency department visits across 10 sites within a single regional health system in the Northeast, spanning 9 years of data. Rather than only looking at Black and white patients, this study included multiple racial and ethnic groups and also analyzed the content categories of alerts, safety concerns, violence history, and so on. The findings reinforced and expanded on what Agarwal found. Black non-Hispanic patients had 2.6 times the adjusted odds of having a safety-related behavioral alert compared to white non-Hispanic patients. But perhaps the most striking number in the entire study was this. Publicly insured patients, Medicaid recipients, had 6 times the odds of having a behavioral alert compared to commercially insured patients. That's a stronger association than race alone. The study also found that patients with cognitive or neurological conditions had over 7 times the odds of having an alert, and that patients with alerts were more likely to leave against medical advice or elope from the ED. The authors concluded that electronic behavioral alerts are associated with significant demographic disparities and may reflect and reinforce existing healthcare inequities. These are important findings from 2 large peer-reviewed studies, and they deserve to be taken seriously. But I am asking you to do something these studies often don't. Ask the question. Here's what neither study can tell us. Were those flags warranted? Was the behavior that triggered the flag accurately documented? Was it a genuine safety incident or a clinician having a bad day? We don't know. Neither study reviewed the contents of the flags against any objective record of what actually happened during those visits. They counted flags, associated them with race, and stopped there. And here's what's just as important. Neither study asks what would have happened if no flag was placed. If a nurse walks into a room without any advance warning about a patient's history of attacking staff and gets attacked, does that show up anywhere in this research? No. The cost of underflagging is completely invisible. Only the cost of potential overflagging gets counted. The Agarwal study also found that flag patients had fewer labs ordered, shorter lengths of stay, and longer wait times, framing those as evidence of worse care. But shorter stays and fewer labs could equally indicate that clinicians identified the situation quickly, determined the patient wasn't medically complex, and moved appropriately. The study doesn't have the clinical detail to distinguish efficient care from rushed care. Both studies are also limited to urban academic medical centers. The rural critical access hospital, the community ED in the mid-sized town, the safety net hospital in the Midwest, none of those are in this data. Disparate flagging rates by race are a legitimate signal worth investigating. But what I'm pushing back on is the leap from disparities exist to flags are the problem. The flag is a symptom reader. Don't shoot the thermometer. Now let's talk about a study that did something I genuinely appreciate. It actually asked nurses. Seeburger and colleagues at Penn Medicine published a qualitative study in JAMA Network Open in 2023. They conducted semi-structured interviews with 25 emergency nurses at a single academic medical center, exploring how nurses understand, use, and think about behavioral flags in their everyday practice. This is an important context. These were frontline ED nurses, not administrators or researchers talking about nurses. The study used thematic analysis to identify patterns across the interviews, and it also asked nurses directly about racial disparities in flag placement. What did the nurses actually say? They said flags were useful. They described the flag as an advisory tool that gives them advanced warning, the kind of information that lets them mentally and physically prepare before entering a room. Several nurses described specific situations where flag information directly changed how they approached an encounter and, in their view, kept them safer. One particularly striking example involved a flag that noted a patient's history of concealing weapons, which prompted staff to conduct a search that found an actual weapon on the patient. Nurses also described flags as imperfect, unstructured, inconsistently applied, and ultimately unenforceable under EMTALA. When asked about racial disparities, most nurses attributed higher flagging rates for Black patients to the composition of the patient population served rather than to individual or systemic bias. The study was positioned as an exploration of nurse perspectives as part of a broader institutional effort to understand and potentially reform the flagging system. When nurses were asked about racial disparities in flag placement, most attributed higher flag rates for Black patients to the patient population rather than bias. If your ED serves a predominantly Black community, then most of your flags will be on Black patients. That's math, not necessarily bias. But population composition alone doesn't fully explain a disparity when you've already controlled for clinical factors. Both the nurse's answer and the study's challenge to it contain partial truths, and the study doesn't navigate that tension particularly well. Here's my biggest critique of this study. The researchers told the nurses the disparity data before asking them about bias. That's a problem. You've briefed your study participants on your hypothesis before asking them to confirm or deny it, and that's not how you get authentic responses. And yet, even after that priming, nurses largely did not believe race was a driving factor. The study frames that as nurses being blind to their own bias. But it could equally be read as nurses having contextual knowledge that disparity statistics can't capture. Add to that 60% white, mostly women, one institution during COVID. If you wanted to understand how nurses across America think about flags, this sample is a starting point, not a destination. The Gonzales study, also from the Penn Medicine Research Group and published in Academic Emergency Medicine in 2024, did something genuinely novel. It asked ED patients what they actually think about behavioral flags. The study enrolled 25 adult patients at a single urban emergency department. Researchers intentionally sought participants with diverse racial and demographic backgrounds. Each participant completed a semi-structured qualitative interview, either face-to-face in the ED or by phone after their visit. Their interviews explored patient awareness of behavioral flags as a concept, their attitudes towards the purpose and use of flags, and their views on transparency, specifically whether patients should be notified if a flag exists in their chart. The study also asked about the potential impact on care and the emotional experience of being labeled. This sample was 72% Black or African American, reflecting the demographics of the surrounding community. Importantly, none of the 25 participants had a behavioral flag in their own medical record. Despite that, most participants expressed support for the concept of behavioral flags as a patient and staff safety tool. Many acknowledged that the violence in the ED is real and that staff deserve advance warning. Some participants expressed that a flag might actually motivate them to demonstrate more positive behavior during future visits. Others raised concern about the fairness of flags being placed without the patient's knowledge and suggested that notification and transparency should be standard practice. The study's primary recommendation was a model similar to the VA's approach. Disrupted behavior committees that included patient input, periodic review of active alerts, and post-discharge notification of flag placement. Now, let's be direct about why this study's limitations matter a great deal. None of these 25 patients had a behavioral flag in their chart. Not one. So what we're actually measuring is what people with no personal experience of being flagged think might happen to someone who is flagged. The patients most affected by flags, the ones who carry them into every visit, were not in the study. The questions were also largely hypothetical. What would you think if you had a flag? Is a very different question from, how did it feel when you found out you had one? Hypothetical thinking is cleaner and less emotionally charged than lived experience, so the study's findings may significantly underestimate both the fear and the burden that a flag actually creates. What the study does well is surface what patients want if flags are going to exist: transparency about placement, the ability to provide their own account, and some kind of review or expiration process. The VA health system has been doing a version of this for years. Periodic review of behavioral flags by disrupted behavior committees with patient input built in. That's worth looking at. But let's be clear about what this study does not say. It does not say patients want flags eliminated. It does not say flags make patients feel unsafe. The nuanced message that safety tools can be supported and improved at the same time is worth honoring rather than flattening. Now we get to the study with the most telling title, Lower the Flag. Kopp and colleagues from UCSF published this in Health Equity in 2024, and it stands apart from the other studies in an important way rather than counting flags or asking people about them. These researchers actually read what was written inside them. The study analyzed 619 active behavioral alerts in the electronic health records of an outpatient general internal medicine practice. Using qualitative content analysis, 2 physician coders reviewed each alert and categorized its content into themes. The 6 themes they identified were venting, alerts that express clinical frustration with no actionable guidance; criminalization, alerts that use law enforcement language or reference criminal behavior; advocacy, alerts intended to help future providers understand a patient's situation and needs; care coordination, alerts that communicated logistical or clinical management information; implied overuse, alerts that suggested limits on resources or services the patient was perceived to be misusing; and safety, alerts that documented specific safety threats or incidents. The study found that the majority of active alerts fell into the venting, criminalization, or implied overuse categories, uses that the authors argued go well beyond the legitimate safety purpose of behavioral alerts. Demographically, patients with active alerts were more likely to be male, publicly insured, and from a lower income zip code, and Black patients were overrepresented relative to the clinic's overall patient population. The authors concluded that the alert system was being used for purposes it was not designed for, functioning as a tool to manage clinician frustration, restrict resource access, and label patients in ways that could bias future care. But here's where we need to pump the brakes on how the study gets interpreted. This was an outpatient general internal medicine clinic, not an emergency department. The entire context is different. Flags placed in primary care, where patients have established relationships with providers and where violence is far less common, should look different from flags placed in an ED where a clinician encountered a stranger in crisis at 2 a.m. and was physically assaulted. You cannot look at a primary care outpatient alert study and draw conclusions about how ED nurses use behavioral flags. That's like studying documentation practices in skilled nursing facilities and drawing conclusions about trauma nursing. The settings, the stakes, and the purposes are not equivalent. The study also only looked at active alerts, which means every alert that was appropriately placed, served its purpose, and was then removed by a clinician or committee is invisible. The sample is weighted entirely towards alerts that have lingered, which by definition skews towards problematic use. You'd never study clinical errors by only looking at cases that weren't caught. And the title, Lower the Flag, tells you where the study was headed before the first alert was read. There's nothing wrong with advocacy research, but call it what it is and read it with that in mind. What I take from this study is that unstructured, unreviewed, indefinite alerts are a design problem. Reform the system, don't abolish the tool. The most recent study in our review is Foltz and colleagues, published in JAMA Network Open in 2025. This one breaks new ground by focusing entirely on children, specifically adolescents and children presenting to the pediatric emergency department with mental health or behavioral health concerns. The study reviewed more than 5,400 visits to a single pediatric ED over a 3-year period from 2020 to 2022. Every patient included in the study had completed a structured aggression risk evaluation during their visit, administered by a psychiatric social worker. The tool asks 8 standardized questions covering a patient's history of violent behavior, current agitation, presence of weapons, substance use, and other factors. Based on the responses and clinical judgment, the social worker assigns a risk level, low, moderate, or high. A high aggression flag in the EHR is associated with high risk designation and persists in the patient's chart indefinitely across all future visits unless manually reviewed. The study found that Black youth had 1.9 times the adjusted odds of receiving a high aggression behavioral flag compared to white youth, almost twice the odds, after controlling for age, sex, insurance status, and documented risk factors in the evaluation tool. In one particularly striking subgroup analysis, the researchers isolated children whose only documented risk factor was a prior history of violent behavior. No current agitation, no weapons, no substance use noted during the visit. Within that group of 299 patients, Black children had 4 times the odds of being labeled high risk as white children. Hispanic youth, by contrast, had significantly lower odds of being flagged high risk than white youth, about 35% of the odds, a finding the study does not fully explain. The authors frame their findings through the lens of adultification bias and anti-Black anger bias, suggesting that clinicians may perceive Black youth as older, more threatening, and less amenable to therapeutic intervention than white youth demonstrating the same behavior. That is a serious finding, and it deserves to be taken seriously. If Black children are being labeled high aggression risk at higher rates than their actual behavior warrants, that shapes how clinicians approach them, shapes whether they get therapeutic engagement or security-focused management, and follows them through subsequent visits indefinitely. That matters. Now let's talk about what this study can and cannot actually tell us, because the gap is significant. The 4-to-1 odds ratio that everyone is citing, that's built on a subgroup of 299 patients with just 3 white children in the specific cell driving that comparison. 3 children. When your denominator is that small, a single data point can swing an odds ratio dramatically. That doesn't mean the finding is wrong. It means we desperately need replication before it drives major policy changes. The study also can't separate current clinical judgment from the shadow of a previous flag, because once a high-risk flag is placed, it stays in the chart permanently unless someone removes it. Some of what we're calling disparate flagging might actually be the cumulative effect of flags placed long ago persisting into current visits. Here's what the research simply cannot tell us. What were the full behavioral histories of these children? Were there documented episodes of violence in their charts, school records, or law enforcement contact that informed the social worker's judgment? Or was the flag based on nothing but race? Without that data, bias and clinical knowledge not captured by the tool look exactly the same in the numbers. And one more thing that tends to get dropped. Hispanic youth in this sample had significantly lower odds of being flagged high risk than white youth, just 35% of the odds. That's a protective effect for another minority group within the same system. If this were simply a story of racial bias against minorities, that finding doesn't fit the narrative. The reality is more complicated, and more research, not sweeping conclusions, is what's needed. All right, we've been through all 6 studies. Now let's talk about what they collectively do not say, because that gap is where a lot of the distortion in this conversation lives. None of these 6 studies demonstrate that any specific flag was placed without justification. Not one. They show statistical disparities at the population level. They do not, because they cannot, look at an individual flag and say, this one is wrong. A disparity in flagging rates is a signal worth investigating. It is not proof that any particular nurse or healthcare provider placed any particular flag out of bias. None of these studies measure the cost of not flagging. Nowhere in this literature does anyone ask how many nurses were injured because a flag was not placed. Because a clinician from the last visit was too tired to document, or too worried about appearing biased, or didn't think the system would take it seriously. The harm of underflagging is real, and it is systematically absent from this research. None of these studies evaluate whether behavioral flags actually reduce violence when used correctly. The Kopp study notes that flags have not been shown to reduce rates of violence in clinical settings, but it reflects a gap in research on effective implementation, not evidence that flags don't work when used properly. Absence of evidence is not evidence of absence. None of these studies propose eliminating behavioral flags as a solution. The Gonzales patient study, the Seeburger nurse study, even the most critically framed studies conclude with calls for reform, transparency, and better oversight, not abolition. That nuance gets lost when headlines reduce complex findings to "study finds racist flags in hospitals." And none of these studies examine what a well-functioning behavioral flag system actually looks like. They study systems with no expiration dates, no mandatory review, no structured templates, no patient notification, and no appeal process. Hint, all of those are involved in a good flagging system. When a system has none of those safeguards, of course problems emerge. That's an argument for designing better systems, not for concluding that communicating patient behavioral history forward in time is inherently harmful. All right, let's pull this together with something actionable, because I don't do episodes that leave you with problems and no path forward. First, behavioral flags are a legitimate and necessary safety communication tool. The research does not support eliminating them. Your right to know about safety risks before entering a patient room is a professional and ethical imperative. Second, the current implementation of flags in most health systems is inadequate. Unstructured free text, no expiration dates, no mandatory review, no patient notification. Those are design failures, not inherent problems with the concept. Advocate at your institution for structured templates that require a specific incident description, a date, and a recommended review timeline. Third, the disparity findings in these studies are worth taking seriously as a system-level signal, not as evidence that any individual nurse is racist, but as a prompt for institutions to ask whether they have consistent criteria for when a flag should be placed, whether there's a review process, and whether flagging patterns reflect something other than documented violent behavior. Those are institutional questions, not individual guilt trips. Fourth, know your institution's flag system. What does it take to place one? Who reviews them? When do they expire, if ever? Can patients see them? Is there an appeal process? If you don't know the answers, find out. And if the answers reveal a poorly designed system, be the person who pushes for better. Fifth, document specifically. When you place a flag, write what actually happened, not "patient was agitated," but "patient threw a bedpan at staff and threatened to return with a weapon at 02:30 on this date." Specific documentation is harder to misuse, harder to dismiss as bias, and more genuinely useful to the next clinician. And sixth, give yourself grace. You are working in one of the most violent occupational settings in the United States, with inadequate tools, inadequate staffing, and often inadequate institutional support. You are trying to keep patients safe and yourself safe at the same time under conditions that would test anyone. The research is pointing at systems failures. Don't let it be weaponized against individual nurses who are doing the best they can with what they have. These 6 important studies raise questions that the nursing profession needs to engage with honestly. And I hope today's conversation has helped you do that with full information, including the significant limitations of what this research can and cannot tell us. We can hold 2 things at the same time. Nurses deserve robust, well-designed safety tools, and those tools need to be implemented in ways that are fair, transparent, and regularly reviewed. That's not a contradiction. That's just good systems thinking. All 6 studies that were cited in today's episode will be in the description. And if you thought today's episode was informative and helpful, stay tuned. In the next couple episodes, we'll go over the positive aspects of flagging, examples of what institutions are doing, and a new state law that mandates flagging in hospitals. That's a wrap for this episode of the Black Belt Nurse Podcast. If you enjoyed this episode, don't forget to like, subscribe, and hit that notification bell so you never miss a new episode. Drop a comment below and let me know your biggest takeaway. I would love to hear from you. You can find me on LinkedIn and Facebook, as well as blackbeltnurse.com. For now, be safe, and I'll see you in the next episode.